Okay, so I might get started if that's all right with all you. Let me know, make sure that you can just put your thumbs up if you can see my screen. Yep, all good, wonderful, great. There's a few more people getting settled. Thank you, Kate, wonderful. All right, we'll get started. So this little webinar is based on a lecture that I give to postgrad nurses at Auckland University. And it is a very shortened version of a rather sort of large conglomerate of research around nutrition and its impact on mental health. And so I've sort of put it down to a 1 hour format, which makes it a little bit easier to sort of assimilate. And I'm really hoping that you will really start to understand how important nutrition is as part of our treatment when it comes to working with individuals with mental health issues. So a little bit about me. I am a registered nurse. I have been nursing for about 30 years or so. Most of that time was spent in South Auckland, and so I was a crisis team nurse for many years, duly authorised officer, and then worked at psychiatric liaison at Middlemore Hospital. And so we saw everybody that came into the hospital post-self-harm, post-suicide attempt, and obviously in other acute sort of mental distress. A number of years ago, probably about 9 years ago now, I kind of came to a sudden realization as we were sitting in the meeting that we would have every morning. We would discuss the people that had come in the night before, and we'd discuss the people that needed attention that day. And you may recognize this phenomenon is that there were many people that we used to refer to as the revolving door clients. These are the people that would come in, we'd sort of patch up, they'd go away, they'd come back in again. And I remember sitting there thinking, my goodness, surely we can do more. We know that in psychiatry, we have two main standards of treatment in some ways. We have talk therapy, which is wonderful and we know can be incredibly helpful, but sometimes difficult to access for people. And of course, we have medication. And so that day, many years ago, I actually left work and I thought, you know what, I really don't want to be the ambulance at the bottom of the cliff anymore. And I really want to know what else I can do as a nurse, what else I can do as a health professional, that we can look at how we treat someone or support someone with a mental illness, or even better, prevent people from getting unwell in the first place. So I started to do a lot of research. I started to do a lot of reading. I started to join organisations like ACNEM, which is Australasian College of Nutritional and Environmental Medicine. I did many courses and really started to look at how else we can build resilience. What's really important when it comes to mental health? What helps people get and stay well outside of these two main modalities? And, you know, what can we be doing? One of the things that kept coming up to me in my research and in my reading was the impact that diet has on mental health. I was finding study after study after study that just seemed to indicate that diet had a significant impact. And I found this a little bit shocking because I was like, hang on a minute, I've been working in psychiatry for many years, and not once has someone suggested to me that diet might have a significant impact on a person's mental well-being. We all know about diet for physical health. And apart from things like, you know, are they drinking too much V or caffeine, and is that impacting their sleep? We really didn't delve into diet at all. It was just something we didn't acknowledge. So this presentation is very much about some of this research that I've seen over the years, and then also looking at, well, what is it about the diet that makes an impact? What can we do as health professionals? And also looking at supplementation as well. Like, what is it? Is it that nutrients? Are we missing some vitamins and minerals, and that's what's making the difference? So we're going to just before we get into that, it's really important to understand that we know that there are many contributing factors to mental health or mental illness, and that today I'm only talking about one of these things. So it's not that nutrition is the answer to everything, but I do think it's very important, and I do think it's important because we do not, in general, as a medical profession or mental health profession, focus on nutrition very much. And I think we're very scared to sort of focus on it as well, because I certainly felt as a nurse, well, is this outside my scope of practice? You know, am I able to talk to the people, you know, people with mental health issues about what they're eating? So we're going to cover some of that as well. So the aims of this session is that by the end of this talk, you will have an understanding as to the importance of nutrition on mental health. You will understand how macro and micronutrients contribute to mental health and well-being. You'll feel confident to investigate diet and nutrition as part of a patient's assessment and treatment plan. We're going to cover some of the issues around research in nutrition and mental health. We're going to take a very quick look at blood tests and normal values of nutrients in blood tests. We're going to look at some of the challenges when it comes to improving nutrition in those with poor mental well-being, and what we can do as health professionals moving forward. So firstly, I'm just going to discuss some of the research challenges, because when we're assessing nutrition on mental health, it is incredibly challenging. Obviously, we want human studies, not animal studies. Human studies have moral and ethical issues. You can't take a group of people and feed them McDonald's and fast food for 6 months and then, you know, just watch them and see what happens to their mood. Obviously, there's major considerations around that. There's also sort of adherence and monitoring issues. And what I mean by that is, if we take a group of people and we want to have a placebo-controlled trial, for example, and we're going to put half of the people onto a diet of some sort, you know, change their way of eating, you know, how do we really monitor that? Because these things are often long term. It's not like you just do it for a couple of days. You really want people to be doing this for a month or 2 months or longer. How do we really make sure that this has been followed so that we get good research results, basically? There's also not one cause of mental illness. As I've said before, there are many things that are contributing to a person's mental health. So just focusing on one thing may not actually get good results as well. There are many confounding factors. The body does not work in isolation, and there are many nutrients involved in mental health and neurotransmitter production. And often the research studies will just pick up on one nutrient, you know, oh, is it B12? Oh, is it B6? But actually what we find is that nutrients, you know, there are many and they need to work together. And we need, you'll see, understand a little bit further down the track how neurotransmitters don't just need 1 or 2 nutrients. They need a lot of nutrients to be made and metabolized and then utilized in the body. Every body is different, so every body is going to have different requirements when it comes to nutrients. There are genetic differences, of course, and epigenetic differences that make an impact. Human studies are very expensive, and if we're looking at things like food, just changing diet, you know, who's going to pay for that? It's not obviously funded by any drug companies. And when we're assessing supplements and diets, it's like, well, which nutrients or what sort of diets do we want to be looking at? We also want to understand the quality of the nutrients. Some of the nutrients provided aren't very good quality. So, you know, supermarket off-the-shelf nutrients may not actually have what's needed. Food also, we buy food, sometimes it's many days old before we get to eat it, what's actually left in that food in the way of vitamins and minerals. And then we're also looking at the quantity, so the dose of nutrients. And so some studies that I looked at, for example, they would look at nutrients that perhaps aren't really associated with mental health in the first place, And they would use such minor amounts, like just looking at the recommended daily allowance, for example, and then we'll say, oh, well, the nutrients weren't helpful. But actually, sometimes it's the quantity that really makes a difference. Just before I go on, if you've got any questions, pop it into the chat. Often I end up answering the questions as this goes through, so but I'll definitely at the end we'll stop and have some time. For those of you in the big group, just write some things down if you have any questions along the way. So first of all, I'm going to look at, well, what is the correlation between diet and mental health? Before we even jump into that, we know that there is an association of serious mental illness and metabolic syndrome, and that compared to the general population, adults with serious mental illnesses have elevated rates of medical morbidity, resulting in a reduced life expectancy of approximately 15 years. So significant reduced life expectancy. Studies have shown that cardiovascular disease, respiratory and metabolic diseases are the main physical illnesses in patients with serious mental illness, followed by cancer and infectious diseases. Patients with schizophrenia have a poor diet, and this has been shown in many, many studies, characterized by a high intake of saturated fat, low consumption of fiber and fruit. Such diet is likely to increase the risk to develop metabolic abnormalities. And in these studies, they say it is alarming that most excess mortality is associated with preventable conditions. So we already know that people that have a serious mental illness tend to have a poor diet in general, and we also understand that medications contribute, unfortunately, to metabolic syndrome. So we've got a big mess in some ways to begin with. So this is actually a huge problem before we even sort of start looking at, well, what else can we do for these people? So I've really focused this down into some very big studies. I've tried to just summarize the largest studies that I could find looking at the association between food. Often it's depression, because there's not a lot of studies done on schizophrenia, for example, or there are a few in here. So this was a very large study. It had nearly 9,000 participants. They filled in what they called a frequent food questionnaire, and they were looking at the consumption of fast food. And this included hamburgers, sausages, pizza, and processed pastries, so muffins, donuts, croissants, and they were assessed at baseline. And what they did is they followed these people through over time. And participants were classed as an incident case of depression if they reported a physician diagnosis of depression or the use of antidepressant medication in at least one of the follow-up questionnaires. So what this study found is that there was a higher risk of depression associated with the consumption of fast food. And basically what they suggested is that the more fast food they ate, the more likely that they were going to experience a depressive illness. This is a very large study of over 20,000 people. This was done in Switzerland, Swiss study, 15 years and older, looking at the association between fruit and vegetable consumption and psychological distress. And what they were really looking at is the 5+ a day. So we know about the 5+ a day that we're supposed to be eating. And in this study, they found that consumers fulfilling the 5+ a day recommendation had lower odds of being highly or moderately distressed than individuals consuming less fruit and vegetables. A research published in 2017, a meta-analysis about dietary patterns and depression risk. And so a dietary pattern characterized by high intakes of fruit and vegetables, whole grains, fish, olive oil, low-fat dairy, and antioxidants. Now, I'm assuming that the antioxidants are from the foods that they're eating. Low intakes of animal foods was apparently associated with a decreased risk of depression. Conversely, a diet pattern characterized by high consumption of red or processed meat, refined grains, sweets, high-fat dairy, butter potatoes, high-fat gravy, and low intakes of fruit and vegetables is associated with increased risk of depression. So the results from this meta-analysis suggest that a healthy pattern may decrease the risk of depression, whereas a Western-style diet may increase the risk of depression. This was recently published last month, I think in September, looking at a more recent study on ultra-processed foods, also linked to higher risk of depression. So there's research just coming out all the time. And in this research, they found that particularly artificial sweeteners and artificial sweetened beverages appeared to be associated with a risk of depression. There was a little bit of debate and discussion around this, but this is what this study had come to a conclusion. So we can sort of understand that there's an association between diet and mental health. But of course, I was reading all these research studies and thinking, well, what happens if you have a person and you then change their diet? And is it just that a person that is depressed or anxious or struggling with their mental health is going to go for fast foods because it's convenient? So that was my first thing as well. What happens if you take a group of people and you change their diet? Is that going to make a difference? And so that's the question that I really wanted to answer. And in this case, this is me being photoshopped I went to a conference in Melbourne in 2016, and Felice Jacko, you may have heard of her, was first presenting her information on what she called the SMILES study. And this was a study that was designed to exactly answer that question, that if we have a group of people that are struggling with their mental health and we change their diet, we encourage them to improve their diet, will that make a difference to their mental health? So the SMILES study was a 12-week parallel group, single-blind, randomized controlled trial of a dietary intervention in the treatment of moderate to severe depression. So what they did is that they had 67 people. They split the group into half, so to speak. They gave half of them dietitian consults, so they had sessions with a dietitian to encourage them and teach them about changing their diet to a modified Mediterranean diet. The other group had social support for the same length of time, so the same visits and length of time that the others were getting the dietitian input. What they found after 3 months, when they reviewed all the people in the study, is that 32.3% of those that changed their diet, so almost a third of them, were no longer considered to be depressed. So they were in remission, as defined by a MADRS score. Of the people that were in the social support group, 8% were in remission. And the intervention, so the number to treat was 4. So 4 people changed their diet to have 1 person improve their mood significantly. This is what the modified Mediterranean diet looks like. So this was an Australian-based study. They wanted to make it easy for people to follow. So they didn't go full Mediterranean. They did. They really sort of combined it with a normal, in some ways, Australian diet. So whole grains, fruit and vegetables, very much like what we would encourage people to eat now. Still had dairy. A little bit different is that they had very large amounts of olive oil, or reasonably large, 60 mils a day. Nuts and seeds were encouraged, and then weekly legumes. They still had lean red meat, fish, poultry, eggs. Extras, I'm not sure what the extras were, but they also allowed alcohol as well. So in this case, they actually were still up to 2 standard glasses a day, which was reasonably significant, actually. A few months later, there was a couple of years later, there was another study done, also in Australia, also looking at a Mediterranean style intervention. This one was a little bit different in that they supplemented with fish oil. They did self-reported depression score, And what they did is followed these groups also for 3 months, but they stayed on the fish oil for 6 months. Compared to the social group, the Mediterranean diet group reported significantly greater improvement in their DASS depression score. What they also said about this study is that they showed that dietary changes are achievable. Because I think often we think, is a person able or willing to actually change their diet? But they seem to suggest that people were willing and able to change their diet and actually get really good results. The study was looking at people with schizophrenia. Very hard to find studies on people with schizophrenia and dietary modification. But this systemic review looked at 25 clinical trials. 19 out of the 25 trials reported improvement in one or more mental health domains, including psychosis symptoms, cognition, and quality of life. This is another meta-analysis looking at the effects of dietary improvement on symptoms of depression and anxiety. Once again, so this was also published in 2019, strongly suggests that diet can play a role in the treatment and also self-management of depression across the population. So really seems to be some really lovely evidence that changing a diet can actually support depression in most of these studies. This is a really interesting study that was done in France. 31 patients with severe persistent mental illness. So these are people that weren't really responding to traditional forms of treatment of medication primarily. So symptoms were poorly controlled despite intensive psychiatric management. They were admitted to a psychiatric hospital and placed on a ketogenic diet. So very, very low carbohydrate diet, 20 grams a day. So they followed these people up for a year. Now, they weren't in hospital all this time. Many of them had leave during this time as well. So they would be on the diet while they're in hospital. They couldn't control whether they were on the diet when they were out of hospital during this time. But what they found is that there was significant improvement in the Hamilton Depression Rating Scale from 25 down to 7. The Montgomery Asperger Depression Scale also, that's the MADRS scale, from 29 to 10. And among the 10 patients with schizoaffective illness, the PAN scores improved from 91 down to 43. And obviously there were significant improvements were involved with observed with their metabolic health as well, as you can imagine. And just a few statements from this study. Following the ketogenic diet intervention, so 10 patients with a primary diagnosis of schizoaffective disorder exhibited improvement in PAN scores. All 23 patients with depression exhibited improvement in HAM-D and MADRS scores. And that by the end of the intervention, the number or dosage of psychotropic medications had been reduced from 18 to 28. In 18 of 28 patients, and among the 7 patients who were also taking non-psychotropic medications, the number and or dosage of those medications were reduced in 5 out of 7 patients. And there was also some reduction in other medications, metformin, insulin, etc., especially regarding related to diabetes. So changing a person's diet from a standard Western diet may improve mental health. So I began to get very curious about, well, what is it about changing a person's diet that has such an impact on their mental health and well-being? Is it just that they're vitamin deficient? And so providing them with vitamins and minerals are actually going to improve their mental state? And what might that mean in the way of supplements? You know, can we supplement our way in some ways to mental health? So first I wanted to look at, well, what are the associations between nutrient deficiencies and mental illness? And so a few studies here, this was looking at zinc, iron, copper, and selenium intakes. The US study, people who met the recommended daily allowance for total zinc, copper, and selenium intakes had significantly lower prevalence of depression. So this is just an observational study. a lot of words on here, but there's a couple of really important things in this study. Both low folate and low B12 status have been found in studies of depressive patients. An association between depression and low levels of these two vitamins is found in studies of the general population. For those of you that don't know, low folate levels are also associated with a poor response to antidepressants, especially SSRIs. And so when we have someone that is treatment resistant on an SSRI and they are given some folic acid or folate, that can often improve their response to antidepressants. There's also something in this study that they talked about epigenetics, and that for some people, they have a very difficult time actually metabolizing folate. And so they actually do need extra folate to support their mental health. And so for this study, they actually suggested that oral doses of folic acid of 800 micrograms daily and vitamin B12 of 1 milligram daily, so that's quite a high dose, could be tried to improve the treatment outcome in depression. This study is looking at the comparison of B12, vitamin D, folic acid. Now, just to remind you, we don't test the folic acid levels in blood, we test folate. Folic acid is a synthetic form of folate. So this is looking at patients with schizophrenia, drug addiction, and controls. 189 patients with schizophrenia, 119 patients with substance abuse disorder, and 109 healthy controls. And they were looking at information B12, folic acid, vitamin D. Vitamin D deficiency of less than 30 nanograms per mil was more common in the group of people with schizophrenia than in the substance abuse and the healthy control groups. Significantly higher numbers of patients in the schizophrenia group than in the substance use group had vitamin B12 deficiencies. So quite significant difference. 45% of those people with schizophrenia had low vitamin B12. So there's definitely some vitamins, and often these are the ones that will show up again and again, that seem to have an impact on mental health. This is looking at omega-3. So omega-3, we understand omega-3s and, healthy fat and things like salmon and walnuts. And this was looking at omega-3 levels in people in a prison in New South Wales. And they really wanted to know, well, what's the commonality between omega-3 deficiencies and behavior disorders or aggressive attention deficit disorder? And this study found that there was a high variability in omega-3 status of the prisoners, but those with lower omega-3 index were found to be more aggressive and had higher ADD scores. Some really interesting stats around vitamin D deficiencies. Now, this is something that we don't often test, and most of the time people will have to pay for it unless we have significant reason to believe, and we can actually support that to be funded. But this is something I will often tell the people that I work with, go and get your vitamin D levels checked. This study was in the UK. Now you might say, well, it's in the UK, there's not enough sunshine in there, everyone's going to be vitamin D deficient, but just sort of hold that thought. So this was looking at 104 adult patients admitted to a psychiatric hospital in the UK. They found that 49% were vitamin D deficient, so serum levels of less than 30. So deficiency is defined as serum levels of less than 30, and insufficiency is defined as levels less than 50. So a further 42.3 were vitamin D insufficient. So on admission to a psychiatric hospital, only 8.7 of the patients were vitamin D sufficient. So this is significant, and it's significant not only, of course, about what does this mean, like what is, does treating their vitamin D, does that mean anything to their mental health? We can look a little bit at that, but also it's significant for musculoskeletal health. Immune system is very dependent also on vitamin D, and also why is it that they're deficient? Is it that they're not getting outside enough? What else is going on within them that is contributing to vitamin D deficiency? Now, vitamin D actually requires magnesium and vitamin K2 to actually be absorbed and assimilated. So as usual, it's not just one vitamin that we need to focus on. I managed to find this research article, the study that was done on vitamin D in New Zealand, and this was done in Waikato Hospital. So 102 consenting subjects, and 75, so 74% of those people in the psychiatric unit had vitamin D levels of less than 50 nanomoles. So they had at least a mild deficiency. So you'd think here in New Zealand that that wouldn't really be an issue, but it does seem to be quite a significant issue in those experiencing serious mental illness. We have to consider also that people that have darker skin are less able to absorb vitamin D. Vitamin D also varied by diagnosis, with schizophrenia associated with markedly lower levels than people that were experiencing mania and depression. So this is something that I think we really should be keeping an eye out for, and we should be checking the people that we work with regularly. General deficiencies in New Zealand, really hard to come across this information, but according to the Ministry of Health, 27% of ordinary population are below the recommended level of 50 nanomoles per litre. 11% of New Zealand women have low iron stores. We know that low iron, low hemoglobin, definitely associated with poorer mental health, low energy, for example. A 2001 study found that 45% of adolescent women were at risk of low dietary intakes of iron, and up to 13% of women between the ages of 15 and 49 had suboptimal iron levels. B12, 20% of individuals have B12 inadequacy. So this isn't a deficiency. They were looking at less than 221 picomoles. I think the deficiency is usually 150 and below. South Asians had the lowest vitamin B12 concentration. Māori Pacific, East, South, East Asians had the highest. There are some drugs that are associated with high risk of vitamin B12 deficiency, metformin being one of them, and long-term use of PPIs. So PPIs are my little sort of pet hate. So many times people are prescribed them and they are not deprescribed or unprescribed. Ideally, they should be short-term. When we are on long-term PPIs, it reduces our ability to absorb nutrients, and this can have a significant effect on our mental state as well as obviously our physical health as well. Zinc, Pacific children had highest prevalence of low zinc, followed by Māori and New Zealand European children. So zinc is an issue in childhood. Selenium, 23% of children are seen to be selenium deficient. Now we know that selenium is really important for our thyroid. New Zealand soils are significantly deficient in selenium. So this can be a real problem even if you have a very, very good diet. In postmenopausal women, approximately 50% are below the estimated average requirement for selenium intake, and 11% are at risk of compromised thyroid function due to extremely low selenium intake. Those that don't know, a couple of Brazil nuts a day will give you your selenium. So there appears to be some nutritional deficiencies associated with poor mental health: vitamin D, omega-3, folate, iron, zinc, magnesium, selenium, and B12. And these are only the ones that we've sort of looked at, that research has looked at, decided to sort of pick these ones out. Just want to briefly cover blood levels. So it's a wonderful idea to get a blood draw done, look at these levels such as B12, folate, iron, for example. But it's really important to understand that just because it's within reference range, it doesn't necessarily mean that it's normal. When they do these reference ranges, what they do is they take blood from 200 people that are apparently well. how they define how well they are is a bit challenging, but they get these levels, and then of course they have this wonderful bell curve that we know and understand. So everybody, the majority are within 95% or whatever, and then those outliers are considered sort of outside of reference range. But there's a few things around that. One is that if we, for example, deficient in selenium, and then we go testing selenium, what does that actually mean? Are we all a little bit on the low? Optimum levels for individuals might actually be quite different, and borderline might not be good enough, and may even be seen as deficient. And I've certainly had that experience myself, where I've gone to the GP, I'm tired, I'm not, not functioning very well. I get my test, blood test done. I always ask for the results. This is especially many years ago, before you could just access them yourself. And that, everything is normal. And then I'd get my results and I'd look and I'd see that my ferritin was 21, and if it was 19 or 20, I probably would be, oh no, you're iron deficient. Therefore, we're going to give you a prescription of a ferrogradient. It's so important to really look and actually not just say, oh, yep, everything's all green, there's no red things highlighted. It's so important to look and compare blood levels to previous levels as well. I've talked to this about blood levels also with Dr. Julia Rutledge. Now, Dr. Julia Rutledge, will talk about some of her research shortly, has done a lot of studies looking at vitamin supplementation and mental health issues. And they take baseline bloods and then give people a range of micronutrients. And what they found is that even people with relatively good baseline blood levels can still benefit from having extra supplementation. So what she means by that is that they still found they had a mood improvement or improvement in their symptoms. So we just need to sort of be aware of that just because it's within reference range, it doesn't necessarily mean that that's optimum for that person. So does taking a vitamin or mineral supplementation help? And this is a really interesting question, because obviously if we knew the answer to this, perhaps it's something that we could easily just, give to everybody and say, well, this is all good, this is going to help you. It's a little bit more complex than that. However, assessment of omega-3 polyunsaturated fatty acids in depression, a meta-analysis. This has been confirmed in a number of studies now that there is an observed beneficial overall effect of omega-3 polyunsaturated fatty acids in patients with major depression. And this has been shown to be again and again and again that especially DHA as part of the polyunsaturated fatty acid helps to improve depressed mood. So we actually get a real improvement in mood. This is looking at the effects of vitamin and mineral supplementation on symptoms of schizophrenia. What they suggested is that vitamin B supplementation, including B6, B9, and B12, reduce psychiatric symptoms significantly more than control. And so, there is some benefit, at least for this group of people, especially B vitamins, in the treatment of people with schizophrenia. This is looking at methylfolate. So just to understand that methylfolate is the more natural form of folate. Folic acid is the synthetic form and needs to be metabolized in our body to become folate, so to speak. So this is looking at methylfolate as an adjunctive therapy with SSRIs and SSRI-resistant major depression. So I mentioned earlier that folate can be really important to add to a treatment regime for someone that has treatment-resistant depression. They were actually looking at doses of 15 milligrams a day, which is a huge dose, but it did show greater efficacy compared to just continuing SSRI therapy, and this was compared to a placebo. The number needed to treat for response was approximately 6. So 6 people had the additional folate in order to actually have an improvement in their mood. So this seemed to be a significant benefit. We often don't prescribe methylfolate. I don't even know if it is available actually on prescription. Someone might be able to answer that. This was a very large publication done last year looking at the clinical guidelines and the treatment of psychiatric disorders with nutraceuticals and phytoceuticals. So vitamins and minerals and other plant-based products, basically. And what they found from there was that there is high evidence for omega-3 fatty acids, vitamin D, less high but still appropriate. They were looking at probiotics, zinc, methylfolate, not folic acid, SAMe, which is another supplement that is often being used in depression, and in bipolar disorder. Omega-3 had a weak support. Vitamin D, NAC, N-acetylcysteine, methylfolate were recommended to varying degrees. So there's a lot of research now really supporting that there are some nutrients that actually can make a difference to a person's mood. This is a study done by Julia Rackledge, who I mentioned earlier. So this is really interesting. They were doing studies, and I'm not sure what the original study was, but they had a group of people, some were on a placebo, some were on different types and different quantities and qualities of micronutrients. And what happened is that they experienced the Christchurch earthquakes while this trial was going. They were able to then assess who was recovering from the earthquakes better out of their group of people that were on the micronutrients. And so they had 91 adults and obviously experienced heightened stress for the 2 to 3 months following the earthquakes. They were randomized to Barocca, and then there was other low dose or high dose micronutrients. So all groups over time found significant declines in psychological symptoms. However, the group on the high dose multivitamin, the CNE8, reported greater improvement in mood, anxiety, and energy, with twice as many reporting being much to very much improved and 5 times more likely to continue wanting to take that as opposed to the Barocca group. So this is really interesting information, and they've gone on now to say that actually micronutrients seem to have a real positive benefit for post-traumatic stress disorder. Really interesting information. This is a really lovely study looking at the effectiveness of single nutrient versus broad spectrum multivitamin or micronutrient in the treatment of premenstrual syndrome. So women with severe premenstrual syndrome are often given an antidepressant or the oral contraceptive pill as a way of treatment. And this really wanted to know, well, what difference will a micronutrient have? And what they found is that after 3 cycles, 72% of the women in the multi-nutrient group and 60% of the women in the vitamin B6 group were in full remissions from PMS symptoms. So super interesting info. And I have seen this clinically as well. I have certainly had women come through the door and their biggest issue was PMS. And with some changes in diet and some extra multivitamins by the 3rd month, like in between the 2nd and 3rd month, they're like, I'm all good. I don't need to come and see you anymore. So it's quite amazing. This is looking at the influence of supplementary vitamins, minerals, and essential fatty acids on the antisocial behavior of young adult prisoners. This was a randomized placebo-controlled trial, and they were looking at 231 young adult prisoners. And they wanted to compare antisocial behavior before being on supplements and after being on supplements, and obviously compared to placebo. And what they found is that those receiving the actual capsules, the active capsules, committed on average 26.3% fewer offences. Compared to baseline, the effect of those taking active supplements for a minimum of 2 weeks was an average of 35.1% reduction in offences. So I think this can really sort of branch out into what does this mean on a sort of global scale, like people that have very poor diets, is this actually impacting on their behaviour as well? And also, if we think about inpatient treatment and behaviours in there that might be seen as antisocial, could this have a significant impact on people that are admitted into sort of psychiatric units? So vitamin supplementation may be helpful for some people. Next, we're going to dive into the question is why? What is it about vitamins and minerals? What makes a difference to our minds and how we think and how we feel and how we act? Don't get too caught up in this because I've simplified this a lot. But this just shows the synthetic pathway and metabolism of melatonin. Now, the reason it's melatonin is that the precursor to melatonin is serotonin. So we all know about these wonderful neurotransmitters. Where do they come from? Well, they actually come from dietary tryptophan, which is an amino acid that we get from protein. In order to assimilate and metabolize, we need certain nutrients. And these nutrients will start to be a little bit familiar to you because we need folate. We need vitamin B6. Question mark around zinc and magnesium. Folate, B12, vitamin B6. So for the cells to actually work and function and actually make these neurotransmitters that our brains and our body needs, we actually need the amino acids that come from protein. So we eat protein, eggs, meats, legumes, grains, soy. They get digested obviously in our gut. This is why it's so important to have a healthy gut and really low pH, so high acidity in the gut. And this is where PPIs can become a problem, proton pump inhibitors that are decreasing your gastric acid. Because if you don't have good gastric acid, you are less able to break down and utilize the vitamins and minerals and proteins that we get. So the protein's broken down into amino acids, tryptophan, tyrosine, phenylalanine, glutamic acid. With this, we need the cofactors. The cofactors are the vitamins and minerals. Vitamin C, folate, zinc, iron. There are many more. I've only put some down there. In order to make neurotransmitters that our body and our brain needs. So important. And honestly, when I've told this, I often tell clients this, I tell patients this, they get it. They really understand, oh, okay, so diet, what I eat, what I put in my mouth, why I need these vitamins and minerals can make a significant difference to how I feel. What else really matters when it comes to diet and mental health? Trans fats. So trans fats are found in baked goods and highly processed foods. They're found in margarine. So those of you old enough to remember those times that we were told to stop eating butter when we should be eating margarine. Unfortunately, they figured, oh, no, margarine's really high in trans fats, actually not very good for us. These studies have looked at mental well-being, and especially in regards to aggression, as well as irritability, and they found that there's a relationship between trans fat intake and depression and trans fat intake and aggression. And what happens is that when we consume trans fats, they actually take the place of the good fats, they're like the omega-3s and omega-6s that we want to have. They take the place of that in the brain cell, because our cells are very fatty in some ways. We've got a lot of fat, but actually takes that place of that fat. And so it stops the normal brain cell communication. So what the study at the top here says that it alters the ability for neurons to communicate. So this is really important. There's also another issue with fats, and that we have a very high omega-6 to omega-3 ratio. So omega-6 is found in lots of vegetable oils, and over the years, we've got now a very high amount of omega-6. There's nothing wrong with omega-6s in the right dose, but what they've found is that because we're having so many omega-6 oils now and fat, this ratio has been very disturbed, and this is also impacting the ability actually for our brains to function properly. For some people, gluten, so this is really sort of throwing a cat among the pigeons, but for some people, gluten is a real problem in mental illness. This is especially, of course, those that have celiac disease, But there are many people that have silent celiac disease that aren't actually ever really tested. You know, they say that the best test is actually via biopsy. There's not many people that get that done. But populations with lower consumptions of wheat have lower incidence and rates of schizophrenia. Small studies have found a beneficial effect of psychotic symptoms of a gluten-free diet. So this is some really interesting things that, once again, we can think about. We know that person does have celiac disease. Obviously, they should be gluten-free anyway, but it could be that it is actually impacting their mental health and well-being. The presence of elevated levels of antibodies to specific gluten proteins points to shared immunologic abnormalities in a subset of schizophrenic patients. So some patients with schizophrenia may actually have a real problem with gluten. This is looking at autism and schizophrenia. And this study was looking at gliadin, which is the protein in gluten, and also looking at the bovine casein, which is the protein found in dairy. In this study, a total of 270 patients, high titer IgG antibodies to gliadin were found in 87% of autistic and 86% of schizophrenic patients, and high titer IgG antibodies to bovine casein were found in 90% of autistic and 93% of schizophrenic patients. A gluten casein-free diet was accompanied by an improvement in 81% of autistic children within 3 months in most of the behaviour categories. So that the data supports the proposal that for many patients with schizophrenia or autism suffer due to absorption of exorphins. So exorphins are opium-like peptides formed from partially digested foods that react with opiate receptors in the brain, and this can cause neurological and digestive issues. So, and mental illness. This is looking at a study that was done on US military personnel. And so when they come into the army, they are very well assessed, as you can imagine. They have loads of tests done. And they were able to do tests on people prior to them actually being diagnosed with schizophrenia. So they did loads of tests. They were looking at IgG antibodies, so immunoglobulin antibodies. And what they found is that those who had a higher level of antibodies to casein, which is a protein in milk, was associated with an 18% increase in the hazard risk of schizophrenia per unit increase. So this study, what they found was one of the first to identify an association between the risk of schizophrenia and elevated antibodies to bovine casein. So just going to run through a few other things. I know we've covered loads of information. Alcohol, probably quite obvious, but several studies have shown that depressed mood is substantially alleviated within a very short time after abstaining from alcohol. I find the same with anxiety as well. And research does show that alcohol raises cortisol levels. So that stress hormone cortisol is raised if they are regular alcohol drinkers. Now, this isn't loads of alcohol. This isn't like, you know, they're coming home and having half a bottle of whiskey every day or more. This is a couple of glasses of wine every night. What they find is that the cortisol levels the following day are raised, which obviously makes you feel more stressed, which makes you want to come home and have another drink or two of alcohol. So it becomes this kind of perpetual cycle. But people that actually sort of reduce the alcohol or stop their alcohol consumption may notice an improvement in mood and anxiety. Smoking cigarettes, we know we're really onto that, I think, now. But it can really affect mood, especially anxiety, and they're wondering whether that's because of the dopamine that you get from a cigarette. You get a little dopamine hit, but then as soon as you finish the cigarette, the dopamine drops again. Every dopamine spike is followed by a dopamine drop. So they do wonder whether that's actually impacting on mood. And of course, smoking would cause inflammation in the body. We know that cigarette smoke also increases the need for certain medications. So that's just something to be aware of. Several studies have linked high sugar intakes with poorer mental health, including stress, depression, anxiety, and schizophrenia. Sugar intake makes significantly affect sleep quality. So this is something that we don't often look at. But once again, we have an issue around sort of blood sugar metabolism and stabilization, and that when a person goes to bed, if they have had a lot of sweet or sugar, you've had the rise of blood sugar levels, you get the drop of blood sugar levels when the person is no longer eating, consuming sugar in bed. Often what they get is they get an awaken response later on in the evening, and it is due to blood sugar level dysregulation. Coffee, evidence supports avoidance of caffeine and anxiety disorders, but if you're depressed, it's actually supposed to be quite helpful, so good news with that. So various other food components may contribute to mental health issues, including gluten, casein, trans fat, sugar, high omega-6 versus omega-3 ratio. So this is just a brief summary before I sort of start talking about what we can do. So diet appears to be associated with mental health. Changing a person's diet may improve mental health. There appears to be some nutritional deficiencies impacting mental health. Vitamin supplementation may be helpful. Various other food components may contribute to mental health. So what can we do? And how do we go about improving diet in people with mental health issues? Now, this is one thing I was really stuck with when I was learning all this information, because I'm like, well, what can I do as a nurse or as a health professional? You know, I'm not a dietitian, and I used to sort of think, well, do I refer everybody to a dietitian? You know, what is it that we need to do? But actually, I ended up ringing the nursing council around this, because I said, well, how much can I talk to people about this without actually going outside of my scope of practice? But we actually have this wonderful, that we have this Ministry of Health guidelines. And if we are talking to people about the current Ministry of Health guidelines, dietary guidelines, we are 100% obviously within our scope of practice. There is nothing, we can't do anything wrong by suggesting that people follow this recommendation. So this was, I think, came out in December, I want to say December 20. So we used to have the old pyramid that is well and truly gone, the old food pyramid. This is what we are currently recommending for people to eat. Now, this may change, of course, because if a person has a milk allergy, dairy allergy, or even intolerance, or they feel better off dairy products, and obviously we would take that out. But basically, plenty of vegetables and fruit, whole grain foods, some milk and milk products, legumes, nuts, seeds, fish, seafood, poultry, and they talk about unsaturated fats. Now, they suggest a canola, rice bran, vegetable oil, margarine. Now, obviously, I would not be suggesting that. Looking at the research, I'm quite surprised they still have this in there. I would simply be suggesting olive oil, extra virgin olive oil. Some people will use coconut oil, but there's issues around that with suggestions of increasing cholesterol and the impact on cardiovascular disease. So that is it. That's kind of what we can definitely follow the guidelines and talk to people about. I worked in a hospital for a while. I went back to Middlemore in a couple of years ago and did another couple of years doing psychiatric liaison work. Some of these photos were sent to me. Some of them have been sent to me from patients in other hospitals. But this is what we are currently serving people. So I know that this isn't psychiatric hospitals, this is general hospital, but I'm quite sure that in many cases the food is the same. So we've got, I think, a real issue. We've got a real disconnect with what we're encouraging and what we want people to eat and what we're actually giving them and what they're actually getting on even in a hospital system. It's quite frightening, I think. You can see there they give margarine, there's no vegetables, there's no fruit. No, I don't even think there's any fruit in any of those meals. And this, there was occasional good meal, absolutely, but I think this is just so important to actually really think about what are we actually doing as health professionals. I know it's not us specifically, but, hospital situation. So what can we do and how can we assess a person's diet? Because if you say to someone, what's your diet like? You can guarantee they'll go, oh, it's okay, or maybe it could be better. And I've had people say to me that they have a very good diet. And then when I've got them to actually go through and list what they exactly eat, it's quite different than what I would expect or what it might you'd hope for it to look like. So I get them to fill in what I call a food mood, but I also use food. So because I'm really looking at, a lot of people have gastric issues as well. So I really want to know if there's any correlation, especially if they do have a sensitivity to dairy. You'll notice that every time they have dairy, they'll end up in the toilet. So get the person to write down everything that they eat and drink over a few days. So breakfast, lunch, dinner, and snacks. Get them to note their mood and their sleep, any gut issues as well. And obviously any alcohol. I haven't added them in there, but get them to add everything that they eat. And often what I find is that the person will come to their own conclusions, that they actually look at all this and they'll say, oh, you know what, I noticed that when I had, I don't know, pizza for lunch that day, I felt really awful in the afternoon. And people start to really see themselves what impact that actually the diet is having on their mood. So I'm going to take you through a couple of case studies. So this was a 26-year-old woman that came to see me. She had mood issues. She was worried about her weight. She suffered from anxiety, and she had a history of depression. And she came to me because she really wanted to feel calmer and be less stressed. She described having terrible hormones, terrible PMT, really not a nice person. She said that her diet was mostly okay. She said she had a poor diet at one stage, but we'll see. You'll see what it looks like. But she was really craving sweet, salty, and fat foods. So she was trying her best, and she was really trying to stick to a very strict diet. But she noticed that she was hungry all the time, and that she really was really craving fat food. She was also doing F45 5 times a week. She wanted to lose weight, and she was doing tennis 2 days a week, but still putting on weight. And she reported that her energy levels were very up and down. So just take a good look at this. This was her food diary. Now, this is someone that she said she was doing her best, and most of the time her diet was good, but then she would just completely fall off the wagon. And if you look at this, I mean, I just took one look at this and went, where is the food in this? There's no real food. There was very few vegetables. She was obviously, I think she was trying to do a ketogenic diet, but I don't think she was getting any support around that. But I just looked at this and thought, oh, I would be starving on this. You know, like, you need to fill your body up with proper food. And this is what she was trying to stick with. And you can imagine why she was absolutely craving, and hungry, starving hungry, actually. So what we did is we did some blood tests with her. I did the usual blood tests. I think there were a few other issues with some of her bloods, but basically we found that she was very low in B12, which we improved with supplementation. And actually all I got her to do was just eat some vegetables. I said, look, I want you to eat as many vegetables as you can. You know, if you're hungry, eat as many vegetables as you can. I don't mind what type of vegetables. I just want you to be eating vegetables. Throw some, you know, vegetables, fruit, and carbohydrates, good carbohydrates in there. And her mood changed, I think, within 3 or 4 weeks. She came back and was like, but I feel completely different. I'm not starving all the time. I'm not, you know, my mood settled, significant. This is a man who was 32 years of age, and he had a history of schizoaffective disorder and anxiety, quite significant anxiety. He had a lot of history of schizophrenia in the family, with his father and his uncle having been diagnosed with schizophrenia. He was still under community mental health services. His mum actually rang me and said, I just would like a little bit of extra input. He was on olanzapine, clonazepam. He was previously on clozapine, but he had a lot of gut issues with this. And he actually continued to really struggle with his gut. And he had a lot of anxiety related to his gut as well. So he was constantly sort of, I wouldn't say obsessed, but very aware of what was happening. He was getting a lot of sort of irritable bowel symptoms, on and off to the toilet. So I got him to do a food diary, and we looked at that, and even he came to the conclusion, he said, actually, every time I drink milk, I get a bit of a stomach upset. And so he was super happy to remove dairy from his diet. We did lots of other things. It was also around mindfulness and supporting anxiety. But he had such a significant improvement in his anxiety symptoms from actually just taking out the dairy, because his gut settled right down. And he actually was discharged from community mental health services a few months later after being under their services for many years. And I actually just sat down with his mum a few weeks ago, and she said he's just doing really well. So sometimes small things can make a really big difference. This is one of the people I first saw when I came back to Miramore, 60-year-old lady, 12-year history of treatment-resistant depression. She was morbidly obese. I can't remember what she came into hospital for, but she was on venlafaxine, sodium valproate, mirtazapine, omeprazole, 40 milligrams. She'd been on for a very long time, lorazepam and clonazepam. And I wanted to put in here, because the first thing I did with this lady is that I went and had a look at her bloods. And her hemoglobin was low, her B12 was, I would say, borderline low, CRP was 24. I didn't mention about inflammation in mental health, but this has a significant impact. And dietary impact can be also pro-inflammatory. And her folate level was 5.6, so also significantly low. So this is someone that I think could have done really well on some extra nutrient support in the way of probably diet. I mean, I always think diet first, but maybe for her, I would actually put her on supplementation with a folate level of 5.6. I think this is the last one, maybe. 44-year-old, main issues of stress and mood. This is a lady that had decided to go vegan. This is a common thing I see. A number of people, especially young women, she wasn't so young, but they watch a documentary and they decide they want to go vegan, and they don't do it particularly well. They just think, oh, well, if I cut out meat and all dairy, I'll be fine. Doesn't always work that way. This woman was very stressed. She was drinking 3 glasses of wine a night. Remember, you know that alcohol can increase cortisol levels. She was very low in energy. She described herself as not good in the morning, very hard to get out of bed, extremely tired and fatigued, didn't have any energy for exercise, very poor sleep, and she was hungry a lot of the time. And this is the sort of diet she was having. She was having bagels, so highly processed food. She had basil pesto on a bagel. She had lunch with bread with salad. Very, very low protein. Probably not enough vegetables in there. Afternoon tea, handful of pumpkin seeds. And for dinner, you know, kale and veggie salad with croutons and vegan patty pieces, probably absolutely fine. But then she was hungry afterwards because she hadn't eaten enough. So I find that for a lot of women, especially that are worried about their weight, they're actually under eating. So it's not that they're filling up on KFC and McDonald's, which we often see. They're actually just really under eating. So she was hungry, so she was having white toast after dinner with olive oil spread. So her diet was pretty similar. And I did a very similar thing. I just got her to eat more food. I think with her, I even got her to eat some eggs. She was able to get some locally grown eggs. She was happy to eat eggs. And I think she might have started eating fish as well. And once again, more volume of wide variety of vegetables. The last one. Female C, 44 years, main issues of stress and mood. So this is the result of her ferritin. Her ferritin was 21. She had high blood pressure and high cholesterol. And so, yeah, this is the result. Increased protein, encouraged alternative relaxation technique as opposed to alcohol. And that actually had a huge impact on her. Stopping the alcohol, I think, was probably one of the biggest things for her. I'm not going to do anymore. So, barriers to eating well. There are many. Reluctance, you know, one of these things that we come across is people are, foods, vegetables boring, may seem tasteless, may give bloating, especially. We're going to feed someone a lot of fiber if they haven't had a lot of fiber for a long time. This may cause some gut disruption. It's often considered unattractive to eat boring old vegetables. But if we look at the studies, most of the studies have actually shown that given the right advice, the right encouragement, and the right support, And especially if they know and understand that changing their diet might significantly improve their mental health, many of them are willing to do so. They really are willing to change. So don't underestimate a person's ability and willingness to change their diet. Other thing that's often talked about is the cost. When they did the SMILE study in Australia, they actually spent less on their weekly budget. Now, of course, this is Australia. It might be quite different, and certainly different in the last few years. But I do think that in many cases, if a person is taught to cook and eat better, that actually it doesn't need to be more expensive. And we also know that there are food deserts in some places. When I've done a sort of look at the areas around South Auckland, for example, there are some areas that there's no supermarket within sort of a 5-kilometre radius, and there's 2 KFCs and 3 McDonald's and 2 Burger Kings. So that can become a real issue, actually having access to fruit, vegetables, cooking facilities, and obviously the ability, the knowledge to cook. So what can we do? What can we do as health professionals? And I do think that we need to be a bit of a voice, because the more we know and understand this information, the more I think we need to stand up and say, hey, this is really important. We be a voice in hospitals and other institutions. Be a voice for organisations, NGOs, for example, respite facilities. Be a voice to government, and we encourage individuals to eat better, and we may even encourage supplementation at times. So a little bit of a how-to guide. Number 1, assess diet with a food, mood, and if you want the gut food side. Assess, improve diet wherever possible, and honestly, sometimes it's simply, can you just add some more vegetables? Studies have shown that even small adjustments, even adding 1 or 2 vegetables, can improve mood, just small amounts. Remove trans fats, ultra-processed foods. We can do blood tests to rule out outright deficiencies, absolutely, really important. If obese or darker coloured skin, immune issues, consider vitamin D testing, maybe add some multivitamins, and consider removing some food groups if there is a suspicion of some issues. And hopefully we may get to a situation that we can swap our antidepressant with an anti-histo flatter. I do run an online course. It's about 4 hours or so. It really goes into a lot of depth about all these things that I've discussed. If you're interested in that, I can send you information on that if you want. There's some details. I also run a Facebook group if anybody's looking at just finding other people that like-minded, that are interested in